Welcome to Peasy Pharmacology. So, on last video we've talked about the factors that impact on the blood pressure. So we've seen that the blood pressure is dependent on the cardiac output, which depends on the heart rate and the blood volume, and also on the systemic vascular resistance. So if you haven't watched that video, I would recommend you to watch it, because then that will be helpful to understand better how the antihypertensive drugs act, because basically they will always change one of these factors and ultimately they will decrease the blood pressure. So let's start with ACE inhibitors. So ACE inhibitors. So basically the ACE inhibitors, they act by blocking the transformation of angiotensin-1 in angiotensin-2. There is an enzyme responsible for this process, which is the ACE enzyme, angiotensin-converting enzyme, and basically it will block the formation of angiotensin-2. As you may know, the angiotensin-2 is responsible for vasoconstriction as well as aldosterone secretion, so it promotes aldosterone secretion. So if we are blocking the effects of the angiotensin-2, we'll have the opposite, so we'll have instead vasodilation when blocked, and we'll have also less effects of aldosterone. Okay, and let's see, aldosterone is responsible on the kidneys for two main things. It's responsible for sodium retention, and it is responsible as well for potassium excretion. And when we say sodium retention, we also are talking about water retention, because normally the water, it follows the salts, the sodium and chloride. So if we have the opposite effect with ACE inhibitors, so we'll have sodium and also water excretion, as well as potassium retention. We'll have the opposite effects. Alright, also before going further, ACE inhibitors, some examples are enalapril, perindopril. All the drugs that end in pril, they are ACE inhibitors. Then we'll have a second class of drugs which is similar to the ACE inhibitors, which are the angiotensin receptor antagonists or blockers, so the ARBs. And the ARBs are basically responsible to block the action of the angiotensin-2. So they will compete and inhibit the angiotensin-2 effects. So basically the outcome is pretty much the same as the ACE inhibitors. Vasodilation, reduced aldosterone, so we'll have more sodium and potassium excretion and more retention of potassium. So they are the main effects of these drugs. But they also have some side effects. So the ACE inhibitors and the ARBs, they can cause, as we see here, hyperkalemia, high potassium. They can also cause angioedema, and specifically for ACE inhibitors, they can cause a dry persistent cough. And why does it happen? So basically the ACE enzyme, it's responsible as well for the breakdown of bradykinin in the lungs. So when it's inhibited, there is no breakdown of the bradykinin, so there is its accumulation in the lungs, so then the patients will suffer a dry cough. And the bradykinin is a bronchoconstrictor, and it's also a vasodilator. So because it's a vasodilator and it's accumulated, sometimes it's thought to help as well with the antihypertensive properties of the ACE inhibitors. But when that's a problem, and normally that's a problem in up to 20% of the patients taking ACE inhibitors, then the doctor can switch it to ARBs, so to angiotensin receptor blockers, and that's, from my experience, the most common reason why patients are put in angiotensin receptor blockers, because they've experienced some dry persistent cough with ACE inhibitors. So I hope this quick video was useful for you. If you liked it, just give your thumbs up, subscribe to the channel and stay tuned because more videos are on its way. See you soon, bye!